Good afternoon, everyone. It's 1:30, so we're going to get started. Thank you all for coming here. And I know it's been a full meeting, and you have chosen to spend the next hour with us, so we are very grateful for that. You're probably like me because you're trying to see where artificial intelligence meets anesthesiology. What's in it? How we are, as anesthesiologists, can shape the future of our specialty. I am Monica Nanda. I'm one of the professors at University of North Carolina in Chapel Hill. And I'm a regional anesthesiologist as well. And when I'm not doing regional anesthesia, I'm also exploring how we can employ the powers of artificial intelligence to advance our specialty. So my work involves using small and large language models to help with curricular development in education, as well as trying to look at how the AI can help with organizing unstructured data and give us a thorough preoperative evaluation when the data sources are in various places. But today, we will be talking about the AI in regional anesthesia. You know, AI is ubiquitous in modern life, and we are stepping into a world of co-intelligence, where humans who built AI are now fine-tuning it for our diverse needs. So in today's session, we have brought together these pioneers who are trailblazing and shaping these tools to advance their specialty, whether it's education, assistive AI, or personalizing pain medicine. And I'm thrilled to moderate this panel with these three leaders. I'm going to introduce you. Our first speaker will be Dr. Chris Schroeder from University of Wisconsin. He's a professor and vice chair of faculty development in the Wisconsin School of Medicine. While his clinical focus is regional anesthesia and acute pain medicine, he augments his clinical career through efforts to enhance faculty well-being. He has written a book called The Essential Guide to Healthcare and Professional Wellness. He is also involved in artificial intelligence and veterinary anesthesia explorations and collaborations. And if that's not enough, he is also pursuing a master's degree in organizational leadership. Our next speaker would be Dr. James Bonis. He is an attending anesthesiologist who is at the University of College of London Hospitals with a clinical interest in regional anesthesia as well. He's an honorary associate professor at University College London, where his research focuses on ultrasound, artificial intelligence, and medical devices. He has published extensively on these topics in peer-reviewed journals and textbooks, including leading several international consensus projects on regional anesthesia and AI, which have been endorsed by societies in anesthesia and regional anesthesia globally. He provides clinical leadership to med tech companies for the development of medical devices in this field, and works at GE Healthcare, developing AI-based devices for point-of-care ultrasound, anesthesia, and critical care. And finally, our last speaker would be Dr. Rodney Gabriel. He's a tenured associate professor of anesthesiology and associate adjunct professor in biomedical informatics at UC San Diego. In his roles as the vice chair of perioperative informatics and clinical director of anesthesiology, he designs innovative AI solutions directly into the operating room, redefining patient care and operational efficiency. His research focuses on real-world applications of AI, particularly machine learning and natural language processing, to solve some of healthcare's most urgent challenges. His work empowers clinicians with tools for better, faster decisions, and ultimately leading to safer and more personalized patient care. So let's dive in and see how intelligence, human and artificial, can work together to make anesthesia and pain medicine smarter, safer, and more personal. So without further ado, I'd like to invite our first speaker, Dr. Chris Schroeder.
looks great. It's really nice to be here. It's really nice to see all of you. I'm going to talk to you just about AI in regional anesthesia education. I have some disclosures, though, none of which are relevant to what we're going to be talking about today. If you do think about how regional anesthesia has progressed over the years, I think we started off, and the way that most of us started is with see one, do one, teach one. You know, from there, we advanced to phantom simulators, PBLDs, didactics. Now some of our colleagues have world-famous podcasts, YouTube channels, and at least from my perspective, I think one of the next domains or frontiers with regard to regional anesthesia education then is going to be the use of AI. Now, if you can picture in your head the best educator that you had, or maybe you're even picturing yourself, those attributes that they possessed would be things like they were organized, knowledgeable, they were supportive and patient, they were engaging and enthusiastic, respectful and professional, they were tireless. You could call them any time and ask them about a patient that you had coming up. They offered you feedback and did so in a constructive way and with strong communication skills. They generated opportunities for improvement with you. When you had difficulty with a block, they guided you towards the phantom or some reading resources so that you would get better when you tried to do this thing the next day. And then their efforts were scalable and targetable. But what I can tell you is, whoever you pictured, whether it was yourself or someone that you encountered along the way with regard to your training, in many regards, AI is better already at this job than this person that you pictured. So those things that AI already can do and do incredibly well is answer questions, it can generate questions, develop curriculum, it can help people prepare for cases and prepare for really serious adverse events that might occur in the course of that case. It can offer you feedback and opportunities then for professional growth. And then as James will talk about later, it's really good then in becoming better all the time with image interpretation. So when you think about education and what the place of AI is, a lot of it comes down to this cognitive load theory, which sort of surmises that each one of us can only assimilate so much information at any one time. And so what AI does then in the course of that education is that it scaffolds information processing, it supports learning efficiency, it improves retention, and it really works well in some of these enhanced or really challenging medical cases. Maybe it's not going to help you so much with the 20-year-old ACL that's coming in tomorrow, but if you really have a difficult patient coming up where you want to think about all the different potential angles, things that might exist within your awareness gaps, AI might exist as a great companion then in that scenario. If you talk to learners who use AI then to augment how they learn different things, what they'll talk about is that through the use of AI, they have an increase in their learning speed, they have improved self-reported performance, and they have more motivation. They want to go out and learn more because they have had this online and omnipresent tutor present to help them get through this information. All right, so let's look at some data as far as how well AI works within the field of education. So this is a really old study published in 2024. It's in the Journal of Cardiothoracic and Vascular Anesthesia. It looked at just ChatGPT 3.5, 4, and BARD. And what it did is it then asked it questions or prompted it with questions that existed within Anesthesia, a comprehensive review. So that text had 884 questions. Of those, though, they excluded any of them that had any sort of imaging. At that point, some of the large language models just weren't well equipped to evaluate images just yet. They tried to make it so that it simulated what existed within the real world. So they set a 70% passing score then for these large language models. And what you can see is that none of those models passed, right? So BARD and GPT-3.5, they were only able to answer less than 50% of the questions correctly. However, I will have you look at how ChatGPT-4 compared relative to ChatGPT 3.5. And while it didn't technically pass, it was pretty darn close. And that the improvement between 3.5 and 4 was pretty darn striking. You can see there were some topics where it did really well. There were some topics where it didn't do quite as well. In general, though, those questions that were increasingly complex or longer were the ones where the large language models really seemed to struggle. What is something that you kind of had to think about is that even though two of the models were only able to answer less than 50% of these questions correctly, the model presented the answers with an extreme amount of confidence in the vast majority of cases. And that's something that really, I think, is something that we should consider as we send learners to these platforms, that there's not a lot of fudge factor in there. You know, if a resident comes to me, asks me about some drug I've never heard about before, I'm going to be pretty upfront about that, and I'm not just going to hallucinate or make things up. And that may not be the case then for these large language models. So if you look at a test that many of our CA1 or graduating CA1s are going to take, this ABA basic examination, you know, this is the one that focuses on the scientific basis of clinical anesthesiology. I'm very grateful in many circumstances that I did not have to take this examination. There was a 2025 study that was again published in the Journal of Cardiothoracic and Vascular Anesthesia that used and prompted a little bit more contemporary large language models to see how well this would now do with questions that were more focused towards that basic examination. They came up with 600 different questions. Again, they had the 70% passing threshold for these large language models. And what they found is that just in that year, now all of the models passed. And not only did they pass, they did so with a really high rate of accuracy. There was no difference observed between those different models, and the models now, instead of performing well in some domains and not in others, it performed well across all domains. And then finally, the oral board examination. This is the one that, you know, at least when I was going through, created the most anxiety in me, and I think is the one that really kind of distinguishes our board-certified anesthesiologist. So what they did then is they evaluated how well the large language models did in answering these questions. They had 4 fellows who completed 2 sample oral board examination questions. They then tasked ChatGPT-4 with answering these same questions. They transcribed and de-identified the responses and then gave them to 8 ABA board examiners. And what they found is that the board examiners were pretty accurately able to detect those responses that did come from the large language model. So they did so about 96% of the time. However, they also thought that the responses from their fellows were ChatGPT generated almost 40% of the time. They didn't really find that either the humans or the large language models had any difference in their overall scores, but that the large language model responses were deemed inferior for a few different reasons here. You know, you can see that they were a little long, they maybe weren't quite as focused as they might have liked, but they didn't hallucinate anything. So the information that they gave was in most cases pretty darn accurate. Okay, so why does the ability to answer some of these trivia questions really matter in the field of education? I think in order to teach, you do, to a certain extent, have to know what it is that you're teaching about. It does sort of validate these tools as an education adjunct. I think it very effectively demonstrates how this technology has rapidly evolved over time and improved over time, and it gives you a little bit of a glimpse of how well this might work then in the future. So what about question generation? So this is something that, you know, any one of our residents or learners or faculty who are looking to master a new technique could do on our own all the time. So here I just came up with a sample. It's please create 5 American Board of Anesthesiology or ABA style examination questions for a senior anesthesiology resident preparing for their advanced examination. The resident has struggled with issues relevant to ankle nerve blocks, and questions that reinforce ankle block anatomy, pharmacology, and indications would be most helpful. Questions should have 3 distractor answers and 1 correct answers, and please provide a rationale then for the correct answer. And what you can see then is that ChatGPT then, over the course of just a couple seconds, generated 5 questions incredibly quickly for me that covered the domains of anatomy, pharmacology, clinical application, block technique, and then complications as well. And when I talk about these large language models being tireless and maybe already better at our job than we are, the first thing it asked me then was, if you like, I can create 10 more questions with increasing complexity, including block failure, troubleshooting, ultrasound-guided anatomy, and local anesthetic toxicity scenarios. And would you like me to do that? And if you hit yes, as soon as it does that, it's going to ask if you want 10 more. And so if you were a learner really looking to strengthen your understanding and knowledge of a certain topic, this is certainly something that you could utilize. Now, curriculum development, I think this is something that we've all put a lot of work into. This is something that requires a lot of work for our typical learners, so our residents, fellows, medical students, but then our atypical learners as well. I mean, with me, I get engineers that follow us around. We get emergency medicine residents, fellows. We get nutrition guys. We have surgery. We have orthopedic surgery residents. And so trying to craft a curriculum then that matches the needs of those learners can be really difficult. In addition to that, our field is one that is evolving incredibly quickly. And so every 6 months to have to tear up this curriculum that we've created to now have to target it towards the new information that's available can be really challenging. AI, though, we can use to harness and customize curriculum development to our learners' needs. So their level of training, their experience within the field, their specialty, the time available that they have with us, right? Do they get a week with us or do they get 4 weeks with us? And then the goals of the individual learner. A lot of times when these emergency department residents or fellows are rotating with me, they're not interested in thoracic epidurals. They want to know what are the best blocks for a hip fracture. And so, can you target a curriculum that is just targeted to what these learners actually want to know? And then our residents can also use this to prepare for cases on a daily basis. So we can use the large language models to target the learning to the things that they're going to be seeing every day. It offers the ability to generate a differential diagnosis, expansive treatment plans, enhanced preparedness for adverse outcomes. Again, you do have to keep in mind that there is the potential there for error. But this case, I'm not going to read it to you, but basically you're a CA2 resident, you have somebody coming for shoulder surgery, they're a pulmonary cripple, they're not doing well, they're anticoagulated. And here in this case, what I've done is I've prompted the large language model then to provide us with some thoughts regarding the anesthetic then for the next day. And what it did very nicely is point out that, gosh, in this patient, the use of regional anesthesia is something that we have to consider very carefully. If you're going to do an interscaling block, you ought to use a low volume of local anesthetic. You should use ultrasound guidance. Maybe you could consider some phrenic sparing blocks. But the fact that this is a superficial block is something that is probably something that's relatively safe in the course of anticoagulation therapy. It gives you and prompts you to consider some multimodal analgesics. And then it very nicely created a table of potential complications that might emerge in the course of caring for this patient, how you could recognize it, and how you could quickly manage those complications. One of the things that I've noticed that we don't necessarily do always entirely well at my institution, and I would wager is something that's not done well everywhere else as well, is feedback. This is something that's sought by our learners, but many of our evaluators and teachers approach with caution, and in many cases, unfortunately, it's not done terribly well. What AI can do, though, is assimilate a variety of different forms of feedback, whether you're just circling a 5, whether you're entering comments, and it can take and compile those things, give empathetic feedback, and create an improvement plan then for our learners that can be used for them to continue to advance. Imaging modalities, I'm not going to touch, but it's just something that's very exciting, as is the other application of technology here. So adaptive learning is basically making it so that these learning systems are evaluating your weaknesses, evaluating your strengths on an ongoing basis, and kind of tailors your education to those strengths and weaknesses, and then continues to change it based on how you do in the future. Virtual reality, I think we've all seen that. But you can imagine that if you were able to marry the two of those things, that you would basically have the Star Trek holodeck, where you could work on improving your skills in an ever-changing environment and one that had adapted to how well your skills were progressing. A little bit of caution. So, Stephen Hawking once said that AI will either transform or destroy society, and it could be the worst event in the history of our civilization. And with regard to education, I think it's certainly true. So all of our biases, that's what we're used to train these models. Everything that we've written, that's now within these large language models. And so if we have prejudices, those sort of things might exist within there. The other thing about these models is that they're not transparent in how they were created. They're also not transparent in how anything you enter might be utilized. And so I think we have to be very, very careful that if our learners are using these models, that they know that they cannot enter any identifiable information then into the large language model when they're creating their prompts. It does point out how there might be a role then for these small language models, so models that are housed on a more local basis, that are built to address smaller, more targeted problems. That's something that maybe could be considered then on an individual institutional basis. And then maybe our kids aren't learning quite as well with this AI adjunct tutor as they think they are. So the constructivist theory of learning posits that there are learners, in order to take information and move it from the short term to the long term, that they really have to work with it. They have to digest it in order for them to fully comprehend the information, analyze, summarize it, and make it so that it's retrievable in an effective manner at a later date. And so one of the things that some of these learners who use AI quite frequently to help them with their education have noticed is that they have a diminished independent thinking ability, they have decreased problem-solving ability, that sometimes our biases and misinformation is perpetuated. They might procrastinate, thinking that, oh, you know what, I can just have AI help me with this the night before. And they don't seem to memorize things quite as well as they did if they were kind of more actively working with this information versus having it fed to them by these large language models. So in the future then, I don't think there is any choice, any other alternative other than just an increased synergy then between humans and AI. I do think that ultimately it's going to be a good thing, on balance, that it will help our learners out, that it is going to help with the development and the provision of effective feedback. Ultimately, if we could have it integrated with some sort of virtual reality platform, that would be amazing. And the other thing that would be great is that, I think, is that eventually we're all going to be wearing these glasses that'll be listening in, that'll be seeing what we're seeing. And at the end of the day, each one of us could get feedback on our performance. The AI could give a summary of how well we treated patients, how great our consent process was versus not, and it could provide us with a daily summary and ways to continuously improve. That is all I have. Thank you so much, and please reach out if you have any questions or if you just want a pen pal. Thank you.
Thanks, Chris. Thanks, Monica. It's great to be here with you guys today. Thank you for your time and listening. I'm going to talk to you a little bit about assistive AI for ultrasound scanning in regional anesthesia. As Monica said, I'm an anesthesiologist in London and an associate professor at University College London. And I also work for GE Healthcare. In addition to my clinical roles at the Anesthesia Journal and leading various AI initiatives in the UK and Europe, my disclosures and declarations are definitely, unlike Chris, related to what I'm about to tell you today. However, I don't view that as a bad thing because I wouldn't be able to tell you this information, share this with you, if my view was not informed by my various academic, clinical, and industrial commitments. I'm going to talk to you about AI, but AI is a broad church, right? Everyone's heard of large language models in the last 5+ years. There's natural language processing, there's precision robotics, there's predictive analytics, and there's deep learning. Deep learning was the cool thing before large language models. Oops, I've gone the wrong side, yeah. There we go. So deep learning was the cool thing before large language models. And AI refers to any kind of field of computer science that enables computers to perform tasks traditionally associated with human intelligence, right? One subfield of that is deep learning, where algorithms encode a neural network. The artificial neuron is essentially a mathematical function which will process data. And you can arrange these neurons in kind of layers. The data passes through that layer, is processed, and then spat out the other side and passed through another layer, and so on. And these layers are arranged hierarchically to provide conceptual depth, so hence the term deep learning. So I'm going to talk a little bit about deep learning today. If we think about how AI is relevant to healthcare and medicine, we're generating more data now than ever before. If you started medical school 1950, you'd have had basically a career's worth before the corpus of medical data doubled. Now it's approximately 2 months. So you can rest assured if you start medical school now, you'll come out knowing a smaller proportion of the body of medical knowledge than when you started medical school. So there's a lot of data to assimilate. We're generating it at an exponentially increasing rate. Coupled with that is a concept called Moore's law, which states that the number of transistors in a kind of processing element will double roughly every 2 years. So sort of aligns to the concept that computational power will double every 2 years. So we've got an exponential increase in computational power. So we've got loads more data and loads more capacity to process it. So there is a lot of data out there. Could we use some technology to extract some meaning from that data to enhance our clinical care? There are a number of ways you can conceptualize AI in healthcare. This is a framework that I like in the sense that you could apply it at a populational level where you're dealing with tens, maybe even hundreds of millions of patients and hundreds of millions, maybe billions of data points, and you need to pick that needle out of a haystack. At an organizational level to do things like allocate resources and enhance operational efficiency, or at a patient level associated with direct tasks, practical or theoretical tasks associated with direct clinical care. So I'm going to pull out one example of AI, deep learning, and apply it to one example of direct patient care. Let's think about ultrasound scanning and regional anesthesia then, because there are two sort of practical steps with performing a peripheral nerve block. Ultrasound scanning, the process of acquiring and interpreting an optimal ultrasound image, and then the needle probe coordination to insert the needle and deposit local anesthetic at the target location. So if we think about ultrasound scanning, ultrasound has been described as the most important advance of regional anesthesia in this millennium, which I think is probably true. Many of you in the room will be old enough to remember ultrasound machines first coming out, and a certain member of this audience has been quoted in a talk as saying it'll never catch on. But if you think 30 years ago when people used to think of it as a sort of snowstorm, and it's this black and white image and you've got to have the eye of faith, now we can kind of, with ultrasound images, really kind of have really high resolution images with the present machines. So we can distinguish anatomy really accurately. However, I wonder if we're a bit too easily pleased, potentially, because, yeah, we've got really high resolution images, but they are cross-sectional, two-dimensional, grayscale images which are trying to inform us on our opinion of three-dimensional, multifaceted colored anatomy. So why do we still use grayscale in medical images? If I give you an example, color is a powerful medium of communication. Many of you will have been driving this week or when you're at home, or when you stop at the traffic lights, you don't stop at one shade of grey and you wait there until the next shade of grey and then you drive off. Okay? You stop when it's red and you drive off when it's green. And that's a life-saving message that is transmitted to you in the blink of an eye and you never even think to process it. A 5-year-old could tell you that message, right? So some of you in this room will be regional anesthesia experts. Some of you will be non-experts or early on in your regional anesthesia journey. This is an image of an adductor canal block. Just below center there, you can see the femoral artery. Okay? Superficial and lateral to that, you can see the saphenous nerve or nerve complex. Superficial to the artery, you can see the sartorius muscle. Deep and medial, you can see adductor longus. Deep and lateral, vastus medialis. Deeper still, femur. I've kind of moved through that quite quickly, and some of you who are maybe less familiar with that image may have thought, I'm just trying to pick up what he's saying. If I said to you, artery's red, nerve is yellow, muscles are green, bones blue, I've gone through that in half the time, and I don't think anyone's not looking at the point that I'm referring to when I'm talking about it, right? So color is a powerful medium of communication. So over the last 10 years, I kind of had this concept of how do we utilize that in ultrasound scanning for regional anesthesia, and there are various devices that do that now. So over on the left-hand side of your screen, you can see a device that I was involved in making, and that was the first of its kind when we took it through regulatory approval in the UK and Europe and the USA. That's called ScanNav. In the middle, you can see a product by GE, which is called C-Nerve, which applies color to the nerve bundles in more limited regions of the kind of interscalene supraclavicular level, brachial plexus, femoral nerve, and popliteal level sciatic nerve, and nerve blocks, which produce another device similar to ScanNav that I produced. So I'll kind of show you a clip now. And this device, inadvertently, I ended up at GE through the acquisition of the team that we used to make this, and so it's not commercially available anymore. So we can sort of talk through it. But Here we can see an auxiliary level brachial plexus block with the artery in red and the nerves highlighted in yellow with fascia overlying conjoint tendon in orange. If I show you the rectus sheath block, you can see rectus abdominis muscle there in green, anterior posterior layers of rectus sheath in orange, the peritoneum and contents in brown. And we'll come back to the adductor canal block. Artery red, nerve yellow, muscles green. So this is a nice concept, right? But actually, is it any good? Is it useful? I'm not going to go. I mean, Chris did a really excellent job of pulling out some really excellent papers. When I did this scoping review, there were about 116 papers at the time, and the kind of search for that was done a couple of years ago. I suspect it's kind of north of 150 now, so I'm clearly not going to go through all of them now. We published this scoping review last year in BJA, where we assimilated all the publications in the field to try and look for various kind of features. And the take-home message is that with this, it's a highly heterogeneous kind of evidence base. There are different teams using different techniques to perform slightly different functions with different block regions, different structures, and different outputs, and evaluating them in different ways. So it's really hard to simply sort of take one kind of approach and compare it to another, because you're not comparing apples with apples. But in the totality of the data, I think, yeah, you can pull out the fact that I think with this concept, there are potential benefits to the operator, particularly the non-expert, in greater confidence in performing that ultrasound scanning, improved acquisition of optimal ultrasound images, improved accuracy and detection of anatomical structures. And so this tool and the stage we're at the minute is, like Chris said, it doesn't replace an expert or clinical judgment, but can augment the performance of a competent non-expert. And the main thrust I see of this kind of technology at the moment, as in more wide, kind of which reflects the more widespread adoption of AI in healthcare, is augmenting human performance. And in this case, to democratize patient access to the benefits inherent within regional anesthesia. As Rodney's kind of previously published, only a minority, typically less than a third of patients who are amenable to a peripheral nerve block are ever offered one. It's not just peripheral nerve blockade, of course, it's central neuraxial blockade for pre-procedural ultrasound scanning. There's a couple of companies that do this as well. So I'm going to show you a quick video of this as well. Here's a spinal ultrasound scan with the identification of the spinous processes, intervertebral spaces. They do other functions as well, such as depth to target and anatomical landmark detection to guide needle entry point insertion, depth to target. And there are potential benefits here. Again, highly heterogeneous database, evidence base, and with a lack of standardization. But yeah, I think there's evidence that you can demonstrate increased first-pass success rate. Studies show really accurate depth to target estimation, which has not been proven, but you could conceive of the fact that that can reduce dural puncture rate during epidural potentially. And interestingly, reduced procedural time, despite the fact that pre-procedural ultrasound scanning is itself typically longer than landmark-based techniques. So, yeah, potential benefits. But as Chris said, there are limitations as well, right? And I don't need to go through a whole talk on what those limitations are to illuminate some of those things to you. I mean, incorrect anatomical structure definition, nerve damage, vascular puncture, and so on and so forth, decreasing the efficacy of blocks. So there are loads of limitations, okay? So that brings me to the thought process of, well, what's our role in this? What can we do to try and maximize the benefits and avoid those, or kind of limit those limitations? And my experience of working in clinical, academia, and kind of technology commercial settings is that typically this field has a high degree of technology expertise and leadership. There's often a lot of commercial expertise as well, but there's relatively modest, at best, level of physician engagement and work in this field. I mean, there's lots of people who are doing good research and clinical initiatives around AI, but ultimately, a lot of the resource in this field and some of the expertise is going to be based within industry. And so I think we need to have a more synergistic approach of how we interact with commercial entities, clinical and academic entities. Otherwise, if it's just a technology-based, technology-led innovation pipeline, we're going to end up with a solution looking for a problem. Because once you've got this shiny new hammer, which is AI, everything looks like a nail, right? So what we need to do is make sure we have good, strong clinical leadership in this space to make sure that it's not technology medical, but medical technology. I'll just close by giving you one example of some initiative that we're doing in the UK and Ireland. We are with the Association of Anaesthetists and the Royal College of Anaesthetists, we're partnering with them to survey all anesthesiologists in the UK and Ireland to say, what are the pain points that are facing you, that you're encountering in clinical practice today? Don't worry about the AI, we'll worry about that a bit later, just tell us your problems, okay? Then when we get the feedback from that survey, that kind of cast a wide net, then the project team that I'm supervising, thankfully not me, I had a lot of work to do to kind of filter through those to kind of determine what's in scope and out of scope. We're then going to have a number of candidate items which will then prioritize, the multidisciplinary team, including industry, clinicians, academics, healthcare policymakers, regulators, healthcare provider institutions, and patients. We're going to try and prioritize those aspects. Say, right, what are the key priorities we need to work on first, the development and adoption of AI in the specialty, and then subsequently, once we've got those high priority items, let's explore them together in a multidisciplinary setting to say, okay, so we said it was a smart ventilator. Well, what is a smart ventilator? What does it do? How does it act? How does it work? What are the benefits? What are the limitations? Where do we need to explore? How do we put the guardrails in? So I'll close there. Thanks for listening, and I look forward to any questions at the end.
Thank you, James. Our last speaker would be Dr. Rodney Gabriel.
Can give your talk. Do you want me to give your talk, James? This is actually his.
You'll do a better job than I will. So.
Yeah, let me see here.
Let's start then. I'm sorry.
All right, so hey, very great to see everyone here today. I'm going to be doing more of a conceptual talk combined with what we can actually operationalize, and it's going to be around how we can actually use AI specifically for personalized pain management. Now, what you see a lot when you go to these AI talks in different medical conferences. You hear what AI can do sort of out of the box, use ChatGPT, ask it to do this, etc. But there's a lot more to it, and we have to really think about, as clinicians who, many of us aren't experts in AI. So we think about, how can we actually use it? And so the term precision medicine comes out, and you hear that a lot. It's a buzzword. Another buzz sort of word is, we do for precision medicine, we do the right treatment for the right patient at the right time. You hear that a lot. What does that actually mean? How can we move that into practice? And that's, one of my goals in, academics and research is to really put a lot of substance in giving the right treatment to the right patient at the right time. And to do that, now we're in a world where AI is in our hands, and AI, all it is essentially pattern recognition. Human intelligence, we practice precision medicine all the time. You're going to see a patient, and you're going to be like in your head because of all the patterns of patients you've seen in the past. You're thinking this patient's going to have a hard time post-operatively pain-wise because of X, Y, Z. So I'm going to do this. I'm going to add, a little bit. I'm going to do multimodal, analgesia here. Maybe I'll do a nerve block continuous catheter. So we're doing precision medicine all the time. But we can do a little bit better now. We can do with AI and all these tools you're seeing, it helps us with pattern recognition, and it'll do a much better job, especially with all the data and complexity of patients we have. And so that's where we need to bring it. All right. And so I know, James, you gave some definitions of AI already. So actually I get to skip this slide, but I was going to define AI, what machine learning is, what natural language processing is, and what large language models are. Add one little thing. So machine learning, essentially, it's, you take a lot of data and you run it through some advanced statistical methods so that when it sees a new set of data, it can make predictions based on patterns. Deep learning was something that came about because there was more computational power available from a technical standpoint. And so the machine learning, the number of parameters that you can put into learning something, it grew exponentially, so it's more computationally advanced. And then large language models came out, which is basically deep learning, but much, 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 much more advanced. We're talking about billions of parameters included into the deep learning model to do tasks that natural language processing was trying to do initially, which is essentially complete a sentence. You ask it a question for a chatbot, for example, and it responds with what they think is the best answer, which is what we always try to do in everyday life with human intelligence. We always respond to cues the best way we think based on the purposes of how we're trying to answer a question. So that's what large language models are. They're a type of natural language processing model nodal for the ability to achieve general purpose language understanding and generation. That is essentially intelligence. As I said, it uses massive amounts of data, learns billions of parameters, and uses a lot of computational resources. And one of the reasons why it came about is because, again, the number of computational resources that we have available to us in computers allows us to learn that many parameters. So this was a daring discourse. A few of us wrote a few months after, or a year after, 6 months after ChatGPT became popular. And it was a hot topic, and it's about how large language models can augment perioperative medicine, a daring discourse. And the bottom line in this article that I want to take home with you is that large language models are here to stay, and as perioperative physicians, we likely must need to adapt to this technology or be curtailed by those who learn to use it well. And so what that means is we're stuck with it. And if I think it's important that you understand it, get good at it, know its limitations and benefits, because that's where the world is going. That's where medicine will go. And so now my focus is on postoperative pain, right? But this can apply to any field in perioperative medicine, in anesthesiology. But here, as anesthesiologists, we're in the business of treating pain, but also avoiding the consequences and adverse events with opioids. Opioids are great. They help with pain, but you can see that there is a crisis out there. And so a lot of things that you see when you go to these pain talks is opioid sparing, right? That's another buzzword. And so you'll see a lot of new treatments and medications that aim where the primary outcome is reduction of opioid use. And so we got to think of ways how we as clinicians can do that every day. And so we do multimodal pain management. So to get better at this is we got to think about two things. And so there's AI and then there's clinical trials. So I bring this up because as clinicians, we're really good at, or some of us are really good at analyzing clinical trials and assessing is this medication or treatment efficacious, right? That's what we do all the time. That's how we change our practice. But most of us aren't good at is applying the same critical evaluation of clinical trials to AI. And so we need to be able to do that also, right? And so once we're able to do that, we can see what actually works. And so when we think about giving the right treatment to the right patient at the right time, and we think about it from a surgical perspective, from postoperative perspective, you have a patient that's going to go to surgery, and then they can go down two paths, the red square or the green square. The red square sort of says they're going to have persistent pain, persistent opioid use, opioid-related adverse events, and by persistent opioid use, most surgeries, hopefully after 3 months, are not be using opioids anymore, but about 20 to 30% of patients getting total joint replacements end up with persistent opioid use. Or you go in the green zone, great recovery in regards to opioids and pain. So we think about what are ways we can get all of our patients to the green zone. Some patients are easy to do that way. Most of them are actually. But there's a few or a select that don't, and we need to figure out who they are so that we can give them the right treatment to that patient at the right time, right? And so I want to give you some examples, because some people will say, why don't we just do the same thing for every patient, multimodal opioid sparing, throw everything at them. Sure, But actually, there's a lot of different services and interventions out there that maybe we can't give it to everybody because of resources and expertise. And so what if those things that are novel, we can apply those to patients that really need these things? And that's where I'm trying to get at in terms of how we can use AI to personalize pain management and do precision medicine. So I want to give some examples of some of those things. We have acute pain services. You hear a lot of things about cryoneurolysis and peripheral neuromodulation. You hear a lot about transitional pain clinics. And you hear about, a big one is non-opioid analgesics like suzetrigine. But again, it's costly, and so you can't just give it to every patient. So a lot of these things have been shown to be very efficacious, but we just can't give it to everybody. For example, cryoneurolysis, we did this study when we did it preoperatively in a randomized controlled trial for patients that got mastectomy. And cryoneurolysis is essentially you freeze nerves, you do it at multiple intercostal levels, so that then it provides prolonged numbness in the chest wall and reduces pain. And essentially what this study showed was that compared to standard care, which was paravertebral catheters, we're looking at a statistically significant decrease in chronic post-mastectomy pain up to 1 year later, and overall decreased opioid use. That's great, right? Limitations, it takes about an hour and a half to do preoperatively. Are you going to do that for everyone? No. Peripheral neuromodulation, that's applying nerve stimulators to, percutaneous nerve stimulators to the nerves preoperatively. It stimulates the nerve, kind of like what they do for chronic pain. That also shows reduced opioid use and pain after surgeries like rotator cuff repairs, ACL surgery, and did a really good job. Are we going to do that for everybody? No. Transitional pain clinics. This is an article we wrote where patients at risk of chronic pain after surgery. These types of clinics that are staffed by anesthesiologists and mid-level providers and nursing can provide a number of things from opioid weaning assistance to interventions to coping skills. To acupuncture. So a lot of these transitional pain clinics do all of these things, right? But imagine how, with all the surgeries that are being performed every year, you're not going to be able to see every patient in a transitional pain clinic. So again, here's another opportunity to do precision medicine in patients that really need it. So my point is that there are limited resources to allocate these services to all surgical patients. And this is where AI can help us personalize pain management. We need something like AI because the EHR data, it's growing exponentially. Right? There's so much data out there. One human cannot just sift through all the data and make these personalized pain medicine decisions. And surgical volume, it's growing. And as you can see, there's shortage of anesthesia providers and staffing. And this is just going to keep happening. And so now we're at a perfect opportunity where we use AI and leverage our data. There's a fly. Leverage our data, and then apply it to all of our patients, screen them for us, and tell us which ones should we do. Everyone will get standard care, but which ones need that personalized pain management? And that's what we're doing. And that's a lot of my research is around doing that. And in fact, it can also transition to, when you look at clinical trials, they're looking at all patients. They enroll all patients. What if we do targeted clinical trials where you only target patients at risk for something? Right? Then you can really show the benefit of, hey, this is how much benefit you can have. And if you run this clinical trial on patients that are getting total joint replacements that are high risk of persistent opioid use, right? And so, there's a lot of papers actually in machine learning predicting persistent opioid use after these types of surgeries, spine surgery, total knee, hip replacement, arthroscopic joint surgery, ambulatory surgery. So there's a lot out there. People are publishing machine learning studies, and this was something that we did where we looked at major spine surgery, looked at thousands of patients at our institution, and we wanted to run a machine learning model and see if we can get all of their preoperative data, not all, but a good number of clinically relevant features, put it into this model, and how well can we predict if someone that's getting spine surgery will develop persistent or can maintain persistent opioids 3 months later. And what this shows you, these are AU, area under the receiver operating characteristic curve, so the closer to the one it is, the more sensitive and specific it is, and we can see this model is showing that we're getting up to 0.9. So now imagine you apply this to our perioperative spine surgery patients, identify which ones are highest risk, sign them up for transitional pain clinics, and that's the patients that you see. And then you can take these models, make them explainable, and it'll tell you what were the features that put them at highest risk of persistent opioid use. And this is in order, so anywhere from age, even their preoperative pain score. So you know, when someone tells you machine learning is such a black box, that's an outdated description of machine learning. I mean, not necessarily, but it's getting more and more explainable, which is great, not always. And in the interest of time, I will you know, show you, these are another machine learning model studies looking at risk factors and models predicting persistent opioid use after surgery. We did the same thing for total joint replacement. So you can also predict those who get persistent opioid use after surgery. And then it's not just EHR data that we need to pay attention to, it's also social determinants of health, and you can use these in machine learning models as well, where it's not just clinical data that puts people at risk of outcomes, especially persistent opioid use, but it's also the environment that they live in. You know, more, as you're gonna see in the EHR, there's gonna be more and more institutions collecting more structurally social data rather than just diagnosis codes. And then as data is growing, we can use that and leverage that for more machine learning models, and hopefully we can start using this for predicting tasks. And so here, what we showed was that things like food insecurity, stress level, loneliness, social support, those were actually associated with persistent pain after surgery. We got to put those in our AI models too for doing persistent, or for doing personalized pain medicine with AI. And that's essentially where we are, is we're doing studies now where we integrate these AI models into our EHR. It tells us who's at risk, and so we know we can practice this personalized pain medicine and see if we can do a better job with those higher risk patients without reducing worsening the outcomes of those patients that aren't as identified as high risk. And that's where we need to go. And so when I showed you this slide earlier, I said, you know, we're good at evaluating clinical trials for the efficacy and effectiveness of clinical interventions. We need to now continue to be better and good at being critical of AI models and not just accept, you know, all these studies that are being published saying, oh yeah, ChatGPT did this and that. No, we have to really think about what it's actually doing and how we can use that to our benefit, you know, rather than being worried that it's going to take over our jobs, you know. So think about, you know, when we think about precision medicine, AI will help us rather than take over what we do. So thank you.
That's a great summary. I think we have about 9 minutes for questions. Sorry, I can see you all better now. So if you have any questions, please come up to the mic and speak, and we'll try our best to answer your questions. Anyone?
Jerry Jones from Memphis, Tennessee. Awesome talk. I was curious about the AI learning. So we have ultrasound machines that can see that's a muscle, that's an artery, maybe your needle's going the wrong way. Have you seen anything that started to analyze the spread of a local anesthetic? Because, you know, when you start, like a half a cc, I know I'm in the right place or not. But sometimes you're above a membrane or below, or they're injecting a little too hard and the pressure's, you know, the local's backtracking. Is there something that's looking at that sort of thing to confirm optimal spread? Thanks.
So we were told to repeat the question just so that kind of when people hear it on the playback. So looking at AI, a potential application of AI to look at spread of local anesthetic, and I presume what you mean is to predict block success or failure, right?
Right. We know what good spread is, and we know what bad spread is.
Uh-huh.
Can the thing tell you, can the AI tell you?
Can it tell us if it's going to, yeah.
Right.
So the short answer, well, forget the short answer because I never give short answers. So that's been thought about, for sure, both academically, commercially, and clearly clinically as well, because that's what a lot of people say that. I've not seen any publications on that yet, and in the work that I'm involved in, it's definitely kind of a subject for discussion. I think the complexity is that we do know, I mean, there are several steps to kind of effective kind of peripheral nerve blockade, right? One is, the first step would be sort of appropriate target identification to say needle, endpoints and so on. And then the next step would be appropriate local anesthetic deposition, as you've gone to. And that, I'm sure that will be part of the evolution. There are a couple of reasons, perhaps, that it's not been the first go-to. One is because there is a somewhat complexity around, I mean, we've all had blocks where we look, that looks perfect. And then 10 minutes later, what the hell why is that not, like, that should be really good. And then you have to say to your resident, it doesn't usually work like this. So I think there is a correlation, but it's not a perfect one-to-one correlation between local anesthetic spread and block success. So there is more to the predictors than simply local anesthetic spread. And the other thing is that these tools at the minute are regulatory approved for pre-procedural use only, at least in the States. That's not the case in Europe. In Europe, you can just do whatever you want. But in the States, they're approved for pre-procedural use only. Because it's a slight chicken and egg situation, isn't it? You're like, well, you've got to get data for them under use in a clinical environment with a needle insertion, local anesthetic injection for them to be approved, but you've got to get them approved to do that in the first place. So that'll come, I'm sure, but it's part of an evolution, and Apple didn't make the iPhone 17 on Go 1, did they? So, we'll if we have this conversation again in 5 or 10 years, we'll be talking about the next generation of these, or the next several generations of this technology. That may or may not even include color overlay. It might be something completely different, but that predictor of block success in which local anesthetic spread will feature will definitely be part of that conversation.
Short answer. I agree. It's great talk, right? Really, really amazing. My question is that, as you all said, it's going to grow, and we are going to be stuck with all this. In the meantime, and James, we talked about it before, that there's a lot of garbage, right? It's garbage in, garbage out. So you have shown me, and we have seen that right now there are things which are, when you ask, it isn't at all relevant. It comes out of AI. So is there a process, or is there anything like he's already doing something in education, you're doing in procedure, whereas Rodney is doing his own data and looking at it, and he's more filtered. So is there right now, what's going to be happen now to 5 years? How do we do what to be aware, okay, this is not true, this is true, because this is not filtered now, right? So what do you guys think is that?
Can I try to answer that question?
Yeah, I was just going to say quickly, are you saying that what I've done so far and the input I've provided so far is garbage? Yeah. I get it.
Yeah. So, Jib, you bring a very valid point. With these multimodal models that we use, Google Bard and ChatGPT-5, they're pulling information from the entire universe of the internet. Whereas, there are more advanced models that have come out, such as Open Evidence is one of those, where it's pulling information. Again, it's not perfect because it's pulling information from publicly available abstracts from PubMed, as well as some of the New England Journal of Medicine and JAMA behind the wall paid access sites. So it's better. It's definitely better than ChatGPT in terms of pulling medical information, because it's retrieval augmented generation, RAG databases, all the medical sources, and not just the vast internet of Reddit and all those things where, it's trying, ChatGPT is trying to generate an output from. So I think we need to look for the models that have a little more authority in looking at literature where it's not garbage that's put in. It's more of a tested, validated medical information. And it is going to get better. I think Open Evidence has its limitations. Again, it's not pulling out from everything. So my guess about the future is that more and more of these protected sites, such as journal sites with full access databases, would become available to these models. and the quality of the output will be much better. At the same time, it's not just the library that matters, it's the smartness of the model that matters. So how well it's going to analyze the questions like a human brain and process it and give you the most relevant answer. I think it will be coming soon. It's already getting better and better. So stay tuned.
Can I? Oh, go ahead, Chris. Yeah, I was going to add to that. So, I mentioned this in my talk where we should also look at AI tools as the same way we look at new drugs and interventions, right? And so an AI tool is developed, it should go, into another study, like a clinical trial, to compare outcomes. So, for example, James, when he started his talk, he talks about conceptually how color and labeling and ultrasounds will help. But he didn't stop there. What he did was a clinical trial that showed that his technology kind of helps, not that much. I'm just kidding. I'm just kidding. But no, it showed that it does. And so now from that, you can say, maybe it's not garbage. It's actually helping because our clinical trial showed that it did. And so the same thing you want to do with AI tools. And that's why I was saying as we are critical with clinical trials, we should be critical with the way generalizability and reproducibility is demonstrated in studies that are comparing efficacy and effectiveness of AI tools. You're not going to be able to do that with everything, just like how we don't do that with every drug and intervention, but that is one way where we as clinicians can critically evaluate AI and determine if it's garbage or not.
And if I could provide a little addendum there, I totally agree with that point. And whilst I've been here, we've kind of met with ASA, APSF about some of these ideas. One of the things that we can do in that kind of medical sort of leadership role in this field to sort of steer the evolution, because regional anesthesia is developed very organically, right? Ultrasound came out and there are like 14 new blocks, and although that's great, there was a slight impediment to actually uptake because the kind of novice user would be kind of overwhelmed, and so there's been a sort of move to standardize regional anesthesia practice in terms of ultrasound scanning, blocks done, and how we do that, how we document it, and that's been a strong movement over the last 5-10 years, right? And I think the medical leadership community could play an important role in developing standardized methodology of evaluation and implementation of these tools so that we are comparing that heterogeneous database, evidence base I talked about. Actually, all studies use the same kind of methodology, metrics, evaluation criteria, so you can compare apples with apples.
And the only thing that I would add is just because these models are imperfect, that's why all of you remain so incredibly valuable. And then the other thing is just, even though these models may not yet be perfect, that doesn't mean you shouldn't be using them because so many people already are. So if you can work and if you can develop prompting that makes, some of the outputs more accurate, more helpful, that's something that's only going to aid you and your learners, and your clinician friends in the future.
And we're also imperfect, yet we do those procedures.
I think we're out of time, but we can maybe do a brief question and then we can adjourn.
It's just super quick. How do we get our hands on that scan nav?
10%. So there is a short answer to this. You can't. So there is that particular tool developed it with a kind of startup I was involved with. G acquired that technology and the team associated with it, and me as well. Hence why I'm now at G. It's still embedded within a training tool provided by a company called Surgical Science, and there's a tool called Needle Trader. We also developed this holographic needle that would you could use it for training. However, I'm obviously employed by one of them, but there are commercial organizations who produce ultrasound machines who produce AI-based software that do this kind of stuff as well. So, I know this is non-CMA accredited, but I'm not going to do a sales pitch and give you 10% off. But, you could go to the booths, or 20% off apparently, Chris, 20% off. You could go to the booths and there are manufacturers displaying this technology like here at the conference downstairs.
Thank you all for coming.